All right, so hello and thank you for having me here today. As you said, my name is Zachary Cooper. I'm from MD Anderson Cancer Center. I work with Jen Wargo over there, who's a surgeon. And I'm talking about understanding response therapy and rationale for combination strategies in melanoma. So I'm going to change, I guess, the theme a little bit and be probably one of the first people talking about cancer in a little bit. So melanoma remains a major cause of morbidity and mortality worldwide. However, within the past decade, key genetic mutations have been identified in melanoma which result in increased oncogenic potential and have been identified as targets for therapy. This includes mutation BRAF, which is at the top up here, and that's found in 52% of melanomas as shown by the recent TCGA data that was just published in Cell. So treatments targeting this mutation has been one of the biggest breakthroughs in melanoma therapy, and the first of these agents was FDA approved in 2011 based on a clear survival advantage over then standard of care chemotherapy. However, there are limitations with this treatment, with the majority of patients progressing on therapy within 6 months. So insight into resistance mechanisms has led to advances in therapy, including the use of combined BRAF and MEK inhibition, which was shown to improve progression-free survival in patients, as seen on the bottom right. However, even with combination, the majority of patients progress within a year, and there's a critical need to identify pretreatment markers of response and resistance, as well as early on-treatment markers of resistance, which are potentially actionable. So through the analysis by our group and many others around the world, we have gained a lot of insight into resistance to BRAF inhibition, and multiple mechanisms of resistance have already been identified. There has also been tremendous success in melanoma treatment using immunotherapy and immune checkpoint blockade. I show data here for treatment with immune checkpoint inhibitors targeting CTLA-4 and PD-1 and PD-L1. And it's important to highlight that though not all patients respond to therapy, however, when they do respond, it tends to be durable. Note the x-axis on the top left graph where you see that extends to 120 months or 10 years out. So, however, there's still a significant proportion of patients who are not responding to therapy. And again, there's a critical need here to identify markers of response and resistance for this form of therapy. So there's now tremendous interest in combination of BRAF targeted therapies with immunotherapies. The basis for this is the fact that in addition to causing increased proliferation and invasion and metastasis, oncogenic BRAF may contribute to immune escape. And we have shown that blocking BRAF using targeted therapy may make tumors more immunogenic. Today I'm going to show our preclinical and clinical data supporting potential between BRAF targeted therapy and immunotherapy. So to gain insights into resistance therapy, we performed longitudinal analysis tissue analysis in patients treated with targeted therapy and recently added immunotherapy. In this diagram, I show our schema regarding time points in which analysis for clinical specimen is done. When a patient is enrolled onto a trial of targeted therapy, they're also enrolled into a tissue acquisition and use protocol. So a pre-treatment biopsy is done before initiation of that trial. Then they get an early biopsy early on treatment, and then we restage as necessary, and then if they progress, we get another tissue biopsy. So then we will perform genomic analysis, immune profiling, as well as RNA sequencing to better understand all aspects of the tissue. So before I go into the patient samples, here's a slide of preclinical data demonstrating that treatment of melanoma cells with a BRAF inhibitor results in increased melanoma antigen expression. So in this slide, we show immunofluorescence for the melanoma antigen MART1. The slide on the left shows melanoma cells cultured in normal media, and then these cells demonstrate negligible MART1. However, after treatment with a MEK or a BRAF inhibitor, you get an increase in MART1. We saw similar findings for all melanoma antigens. So we extended these studies to patients. Here we identified potential immune mechanisms of response and resistance through immune profiling and biopsies. Tumors were biopsied pre-treatment and within 10 to 14 days of initiation of therapy. Tumors were stained for the melanoma antigen MART1 again and for CD8 T cells. So here we demonstrate an increase in melanoma antigen expression and an influx of CD8 T cells, within 2 weeks of initiation of therapy, and this is likely contributing to the response therapy. However, concurrently, we also saw a dramatic increase in PD-L1 on treatment, suggesting a possible mechanism of resistance. So an obvious question that arises is that given the advance in targeted therapy and immunotherapy, can we combine these two treatments to enhance responses? So now I'll share some insight gained not only from patients, but also from a murine model. So with these tremendous advances in melanoma treatment, we are poised with therapeutic dilemmas with regard to timing and sequence of therapy. Should we begin with immunotherapy and then switch to a targeted therapy at progression, or should we start with a targeted therapy and then switch to immunotherapy at progression? So, however, there's critical questions exist in that can we use both these two forms of therapy together at the same time to improve responses? So there's certainly a strong clinical rationale for combining these two therapies for melanoma. This is based on the fact that each of these treatment strategies has limitations given as a monotherapy. Takes, for example, BRAF targeted therapy, where the majority of patients respond. However, it's very short-lived. In contrast, immunotherapy, you have a low percent of patients responding. However, it's much more durable. So, and we're hoping that combination with both of these two strategies will increase the amount of, or create a high response, but also create a durable response. So we want to test the potential synergy of targeted therapy and immune checkpoint blockade, and did this in two manners. We first aimed to perform multiple tumor biopsies in patients being enrolled onto clinical trials combining these agents. One of these trials was combining BRAF inhibitor with checkpoint inhibitor against CTLA-4. Samples were obtained prior to treatment, early on BRAF inhibitor, a little bit later in treatment, about a month in, and then after the addition of CTLA-4, and then far along in the treatment. And we also studied this combination in a murine model of BRAF mutant melanoma, and chose to study the combination of BRAF inhibitor with blockade of anti-PD-1 or anti-PD-L1, given the favorable toxicity profile. So as I mentioned, we didn't accrue many patients for this trial. For serial biopsies, that was closed prematurely. I think Tony Rebus published a paper in New England Journal of Medicine on that trial. But nonetheless, we have some provocative anecdotal evidence of increased CD8 infiltrate in combined therapy. So in this patient, we found virtually no T cells before treatment, and then you saw an increase early on treatment, even though there are some melanocytes there. But that wasn't very surprising. We've already published that in previous data. What was surprising was that the T cell infiltrate was basically gone about a month on. However, after addition of anti-CTLA-4, it was restored, and it persisted for months after he was off both drugs. So we also looked at the CDH Treg ratio by flow cytometry in collaboration with Arlene Sharp over at Harvard Medical School, and these mirrored the findings of the IHC. So we also developed a murine model through a collaboration with Martin McMahon, Marcus Bosenberg, and David Fisher. And this model is based on the original BRAF P10 model in Dancourt et al., and I think it's Nature Genetics. And we backcrossed this onto a C57 Black 6 mouse, and then generated a cell line which demonstrated the same phenotype we saw in the human sample, showing an increased antigen expression with the treatment of BRAF inhibitor. So we use this model to test for synergy. Mice were treated with a control chow, BRAF inhibitor alone, PD-1 or PD-L1 alone, or BRAF inhibitor plus anti-PD-1 or PD-L1. In these studies, we found that addition of immune checkpoint blockade to a backbone of BRAF inhibitor therapy improves responses with enhanced survival and delayed tumor outgrowth. You can see this in the survival plot on the left, where you get some treatment effect with BRAF or PD-1, but when you combine the two, you get a much better survival. These mice also showed delay in tumor outgrowth, as shown on the right. So when you look at these tumors, there is a modest CD8 infiltrate in the setting of BRAF inhibitor monotherapy. However, when you add PD-1 blockade to the backbone of targeted therapy, there's a dramatic increase in CD8 T cell infiltrate in the tumors of mice. Importantly, these infiltrating T cells were also more active. So with this as background, I'd like to share how we've gained even more insight into the resistance to therapy in melanoma, and we'll first describe how we further characterize immune infiltrates in patients with metastatic melanoma. So this work stemmed from elegant work by Lisa Cousins' group, which was published in PNAS, where they analyzed the leukocyte population in breast cancer that was either chemotherapy naive or chemotherapy treated. We basically took their protocol, which we digest tumor biopsies straight out of surgery or out of the clinic, and then we use a 35 antibody panel to do flow cytometry, focusing on T cells, Tregs, NK cells, T cells, B cells, TAMs, TAF, DCs, and PMNs, and use a Fortessa to look at all the different leukocyte populations. Here's the gating strategy, but that's in the PNAS paper, so I'm not going to go over it. So we began these efforts about a year ago. I've collected over 90 melanoma metastases from over 60 patients. In this talk, I'm just going to talk about 39 of them. But results from the analysis of these tumors is highly relevant, as patients were treated with either targeted therapy, namely BRAF inhibitors or BRAF inhibitors plus MEK inhibitors, or immune checkpoint blockade, either anti-PD-1 or anti-CTLA-4. And you can see that we collected treatment-naive patients, patients that are on therapy, and then at time of progression. This is not a longitudinal analysis. This is just collected at different time points. So based on this unique cohort of patients, we use this analysis to see if there's a difference in the leukocyte-infiltrated melanoma tumors when patients progress on targeted therapy versus when they're progressing on immune checkpoint blockade. So this was something that our group wanted to explore after observations by Keith Flaherty and Jen Wargo that the kinetics of tumor progression on targeted therapy and immune therapy may differ. So here we show spider plots with tumor burden on the per RECIST criteria on the left, with individuals compared to the baseline at various time points. The top is BRAF plus MEK, on the bottom is anti-PD-1. Basically, the red lines are all patients that progressed on therapy. Patients who progressed immediately on therapy per RECIST were not included in these cohorts, first of all. So on the right is a graph demonstrating the slope of disease progression per RECIST relative to the pre-progression slopes for targeted therapy or immune checkpoint blockade. And you can clearly see the higher slope of progression for targeted therapy versus immune checkpoint blockade. So when we pulled the flow cytometry data from the patient cohort I previously mentioned, we see some interesting findings, namely that there are clear differences in leukocyte competition between the treatment-naive patients and those treated with either targeted therapy or immune checkpoint blockade. So for this talk, I'm just going to focus on the T cells. So when you look at patients on targeted therapy, we see some very interesting results, namely that the CD8 T cell infiltrate is increased early on treatment with the BRAF inhibitor. However, at progression, they go back down to around baseline. So this is actually reassuring to us, as we've been studying the immune effects of BRAF inhibitor for several years. And we've showed this previously in the clinical cancer research. And these are just representative images from that manuscript. But that was very reassuring to us and helped us validate our methods. However, when we look at immune checkpoint blockade cohort, we see very different results. Namely that the CD8 infiltrate is increased early on treatment, and actually it remains high at time of progression. So we also performed IHC on these tumors and saw very similar findings. In contrast to our CD8 data, we did not see any difference in CD4s in treatment-naive patients versus those on targeted therapy or immunotherapy, nor did we see a difference in the Tregs. However, when you look more closely at the graphs of the percent of CD8 positive cells where each patient metastases is represented, two different groups of patients progressing on immune checkpoint blockade can be seen here. And it's either patients on anti-PD-1 or patients on CTLA-4. So the red dots here represent the patients that are on anti-PD-1, and the black dots are those progressing on anti-CTLA-4. And you can clearly see that the patients on anti-PD-1 have a higher percent of CD8 positive cells as compared to those on anti-CTLA-4. However, we have also looked at the activation panels as well as immunomodulatory panels by flow and don't see any significant findings. We're still trying to understand the differences in these immune infiltrates in patients progressing on PD-1 versus IPI. However, now we're actually sorting out CD8s and CD4s by flow, and we're going to be running RNA sequencing on these to better understand the differences in the populations. So with that, I'll conclude. I think this, there you go. So in summary, we can easily characterize leukocyte components in melanoma metastases. Interestingly, our studies highlight differences in immunophenotypes at progression on targeted therapy versus immune checkpoint blockade. Anti-tumor immune responses should be considered when contemplating timing and sequencing of therapies. And finally, there's much more research that needs to be done. So with that, I'd like to acknowledge a lot of people, but I'll kind of keep it short. Mainly my boss and a postdoc in our lab, Alex Rubin, our team and collaborators is Grant that's funded most of this, Linda Chin, Keith Flaherty, and Arlene Sharp, and many other people from MD Anderson. But most importantly, I'd like to thank all the patients, because it takes a lot of effort for these patients to go through all this and actually do all these biopsies, all these clinical trials. So with that, I'll take any questions.
Thank you, Dr. Zachary. Any question for the Dr. Zachary? No?
No?
Okay. Thank you, Doctor.